May I request Dr. Pavitra Rajan ma'am? Ma'am is a doctoral candidate in physiotherapy at the University of Sydney in Australia, and she is exploring the influence of culture on communities. She holds a bachelor's degree from MUHS and a master's degree from Canada. She is a postgraduate teaching fellow with the discipline of physiotherapy at University of Sydney and has more than 60 research publications in international peer-reviewed journals. She has been invited as a speaker on national and international forum and is keenly interested in culture, rural and remote health with musculoskeletal rehab and evidence-based practice. May I request Dr. Pavitra Rajan ma'am to take over her session?
Thank you, Dr. Shimpi, for your kind introduction. I think my talk today follows on certain similarities between what I've been hearing from Dr. Vimal Telang and Dr. Chitranjan Mishra. So today's talk is going to be my experiential account on my work as a community physiotherapist in India and my current PhD project, which is investigating chronic back pain among Indian migrant communities. Now, if we look at the next slide, you can see a lot of photographs coming up. So this is from, I think, 2012, 2013, when I was actively involved as a community physiotherapist in India. Um, I was heading the research division at an NGO in Gujarat. So most of the photographs with the women and the children are from Gujarat. And we were looking to explore effective interventions for chronic back pain, which was quite prevalent among the urban slum communities in Vadodara with the mothers and the children. I was also had the privilege of working with an NGO in Mumbai then, in the role of a research assistant, and we were looking to improve the quality of life of pediatric cancer survivors and their families. So the photographs on the top left with the child and the top right, where you see a shed with some animals, that's shot in northern part of India in the states of Bihar and Gujarat. So in today's talk, I'm going to give you examples from an Indian setting and my current Australian setting, and the Indian example will be from my work in Gujarat. So if we go on to the next slide, so having worked in different roles in different countries over the past 5 to 10 years, and in the role of a clinician, academician, researcher, and now as a student in community physiotherapy, I've come to realize that there are certain core elements of community physiotherapy which do not change much between countries or settings for that matter. So on this slide, you can see three such elements that have been depicted. And I acknowledge that there are more than three, but given the time constraints, I've just given three examples here. Um, s- but what does vary between countries and settings is the extent of the influence of each of these factors. So, going back to what Dr. Vimal Telang was talking some time back on the a high level evidence on the burden of disability in different settings. So yes, so there is disability throughout the world, but the extent to which the burden is manifested is quite different. So this is on similar lines to that. Okay, so I'll be talking about each of these elements in the following slides. Now let's look at the next slide, which is on type of setting. So if you look at the two photographs, you can easily guess which is the Indian setting and which is the Australian setting. Now, if you look at the photograph on the left side, this was shot in rural Uttar Pradesh. Now, my principal place of work was in Mumbai. So traveling to this remote community in Uttar Pradesh to do some community interventions, it almost took me 40 hours. But to travel from Sydney, that's where I'm now, to this remote community in Australia, it took me about 6 hours. So that in itself can tell you how difficult or how easy it is to reach your target community. And then from then on, you build on the intervention. So no points for guessing. It's very clear that planning an intervention in a rural setting that's closer to my principal place of work would be easier rather than having to travel 40 hours in order to reach your target community. Now, this leads us to the next element, which is on the availability of resources. Now, if you look at the photographs, I've retained the same photograph from the previous slide because it talks so much about the limited resources that community physiotherapists in India can have. Now, if you look at the Australian setting, so that's a photograph of a community center for mothers and children in Australia. Now, there were ample resources in the form of fly in and fly out doctors, community nurses, trained community workers, lay community leaders who were quite involved in the project, and students like myself from the nearby university who would keep visiting these communities often. Now, in terms of financial resources, I would say that the rural community in Australia had relatively more resources from different organizations, from the local governments, compared with what resources I had when I was working as a community physiotherapist in this rural setting in Uttar Pradesh. So I would say availability of resources is something you need to consider when you're planning an intervention for your target communities. Now, this brings us to the next slide on community involvement. Now, if you look at the photographs, this brings some really good memories for me working with children and their families. As you can see, um, when you interact with your community, you will automatically know how involved your community is in your intervention, in your services, and that is an important factor which decides the long-term planning and sustainability of the project. Now, if I can go back to the same example of the rural community in Uttar Pradesh, if it's going to take me 40 hours to go there, I might not be able to do frequent visits. So the onus or the ownership of the intervention then goes on to the community, could be the community leaders or the trained community workers, to sustain the project and plan the project to have an effect over the long term. So now let's go on to look at some case studies. So I've presented two case studies. If we can go to the next slide. So the first one, if you look at the photograph on the right, that's actually an advertisement from one of my PhD projects here in Sydney. So I was doing a cultural adaptation study with the Marathi speaking migrant community here living with chronic back pain. So as you can see that advertisement on the right side is bilingual. So it has English as well as, some script in Marathi. And on the left side, you can see me conducting a focus group with the urban slum women in Gujarat. So that was in the language of Hindi. So this was the language that was commonly understood by that community. So so here what I want to the point that I want to stress here is, despite the difference in the countries, so Australia being a developed setting and India being a developing setting, and the fact that I'm working with urban community in here in Australia, and the one in India is an urban slum community, so different setting, different country. The approach that I've used in terms of language is probably the same. So, the takeaway message from this slide is, we need to identify what the problem is and try to deliver the intervention in a language that's understood by the community. Now, if you look at community physiotherapy in India, this might not come up as an important point because, after all, we deliver all the interventions in the language of the community, given that India is multilingual and multicultural. So, probably if I were to deliver an intervention in Maharashtra, I would probably consider the local language of Marathi. So that goes without saying. But if we do get involved in cross country or cross continental projects, we need to keep this in mind. Now, this goes back to one of the points that Dr. Mishra had brought up on having a national level protocol for the spinal cord injury patients, which is very specific to the Indian setting. So he was mentioning how we have a lot of protocols in the Western countries, but it might not be relevant. Some of the components might not be relevant to the Indian setting. So this goes on those lines. You need to identify what are the needs of your community, and what is the language they understand, what is the best way to tailor your intervention to suit the needs of your community. So if we go to the next slide, which talks about planning your interventions. So if you see, both the photographs are from the Indian setting. Unfortunately, I'm not in a position to share any information on this phase of planning the intervention from my PhD thesis, because either the studies are being written or under review with journals or in the process of being published. So let's discuss just this case example of the Indian setting. So how we went about with this was through the NGO, which acted as a bridge between me, the community physiotherapist, and the target community. I held some focus groups in order to understand what the problem was. So these focus groups were conducted in Hindi. And then we realized that back pain seems to be one of the problems that was on the top list. This is in line with what Dr. Telang just mentioned on, she showed a slide on what are the top, probably 10 chronic health conditions that are causing a lot of disability. And back pain and neck pain was one of them. So not surprised that there was a lot of back pain, not just in the mothers, but also in the children. So then we went, so I did a bit of interaction with the communities in order to understand what their needs were, what kind of beliefs existed. And this goes back to what Dr. Mishra mentioned on the importance of culture and social factors. So trying to understand what the culture was in that community. Then we went back, and what you see on both the slides is a very simple ergonomic booklet, which we developed after getting some useful inputs from the community. This, and one of the ladies you see on the right side is the school teacher. So we also got a lot of support from the school teachers. So trying to involve as many stakeholders as you can in order to make your project as sustainable as possible. So we developed an ergonomic booklet. Now, this ergonomic booklet was based on the chronic back pain guidelines, which have been developed in Western countries. So what we did here was we just put photographs of good and bad postures, right and wrong postures, with a cross and a tick at the bottom. So this was used as an intervention. So when we think about communities and interventions, we always think about very complex and very difficult interventions. But interventions as simple as this have been shown to be quite effective. So then we just did this, like good and bad postures, and we tried to minimize the language we used in the booklet because the mothers were not as educated. So trying to match your intervention to the educational levels, the needs of your community. And then I think I was in Gujarat for a week then. Um, did the focus groups, done the intervention, and went back. And then we recruited two volunteers from the same area, from Vadodara itself, in order to do a 3 month and 6 month evaluation, and then a final intervention at 6 months, which was involved along with the schools. So even after 6 months, we were quite pleased to see that the knowledge levels of right and wrong ergonomics or good and bad postures was still prevalent in this community. So the takeaway message is a very simple intervention can also be as effective. So it doesn't have to be a very fancy intervention. If we go on to the next slide, again, this goes back to what Dr. Mishra was mentioning on consideration of cultural and social factors and trying to have a protocol or an intervention that's very specific to your community. So let me quickly talk about beliefs. Now, beliefs are it's kind of something that we do always. We try to assess the beliefs, but it's not very explicit in our interventions or planning of our interventions. So if you look at the Indian setting, as I talked about, the good and bad postures, the reason that was there in the intervention was we found a lot of biomedical beliefs in this community of urban slum women and children. So biomedical beliefs would mean, they believe that wrong postures are causing their back pain, too much of household work is causing the back pain. So some biomedical reason for the cause of back pain. So based on these beliefs, the way we developed the intervention was a booklet with ergonomic right and wrong postures. So that was effective. And if you look at the Australian setting, which where that is my current PhD thesis, so I can share a bit of information, but not all of it at the moment. So this Australian migrant community here in Sydney has a predominantly biopsychosocial belief about back pain, which is in fact consistent with the current back pain guidelines. So the kind of intervention that we are planning will not be very different to what is there in the guidelines, because the kind of beliefs that this migrant community holds is very consistent with the guidelines. So the takeaway message from this slide is you don't have to do different things always. You might have to do things a bit different, but it doesn't have to be very different just because it's a developed setting or a developing setting. It all boils down to what your community is all about. So you need to understand what their beliefs are, what their culture is, what are the social factors that's will affect the planning or the design or the delivery of your intervention, and then you go about with the development of your intervention. So cultural adaptation is something that's been there for the past 3 to 4 decades, mostly in mental health domain, slowly catching up in our domain as well. I think it's a very smart approach, especially in resource limited settings, which you might encounter quite frequently in a developing country like India. So it's just about adapting something that's already well developed to suit the needs of your community. So I'm not saying that you shouldn't reinvent the wheel and develop a new intervention always. Sometimes that's the way it should be done. But cultural adaptation has been shown to be a very smart approach and effective in the design of evidence-based interventions for different communities, for culturally different communities. Now, I thank you all for coming to my talk. And there's a QR code which you can scan. So given the time constraints, I was not able to give you much information about the different projects that I've been involved in and the projects that I'm currently doing. So if you scan this code, they should take you to a link with a list of my publications and probably help you with some more information on the kind of work that I'm doing and I'm interested in. Thank you.
Thank you so much, ma'am. I think your global experience does help to relate to the needs and advances that are required in our Indian scenario.
Thank
Thank
you.
you once again. And now we go to our last and most senior panelist for today, Dr. Neeta Vyas, ma'am. Dr. Neeta Vyas is PhD and MBA. She has more than 43 years of teaching and clinical experience and has been on post of past principal at SBB College of Physiotherapy, Ahmedabad and IKDRC College of Physiotherapy, Ahmedabad. She has more than 50 publications in peer-reviewed index journal and has been awarded with the IIP Lifetime Achievement Award, the IIP Fellowship Award, Significant Contribution Award, and also the Gujarat Physio Ratna Award. We are indeed privileged to have you over with us, ma'am. Over to you. Dr. Neeta Vyas, ma'am, over to you. I believe we are having some network issues with Dr. Neeta Vyas, ma'am.
Hello?
Yes, ma'am, we can
Hello?
hear you.
You can hear me?
Yes, ma'am. You can
Yeah.
go ahead.
Sorry. Yeah. Sorry, my last moment this has occurred. Disconnecting again.
Ma'am, I believe you are on two concurrent connections.
Yeah, I just one minute.
Sure. No issues, ma'am. Take your time. In fact, one of the primary domains for us in this time is overcoming technological barriers.
Yeah. Sorry, Apura. Hello. Hello.
Yes, ma'am. Go ahead. We
Yeah.
can hear you very well.
Okay. Good afternoon, everyone. First of all, let me thank to the scientific committee, Scientifica, Scientific College, and Dr. Apurva Shimpi for inviting us in this panelist. And the theme itself is saying that think scientific, think research, and think globally. All my three colleagues share in my talk, but the main aim is my achievements in community physiotherapy, what we are doing in Gujarat, because specifically I have been working in Gujarat since last 44 years, and I'm going to share that story to you. I think you can start with my photographs. Uh, these are the photographs. We are going to the villages nearby our college, where we screen the patients in all the areas, whether they have medical problem, whether they have musculoskeletal problem, whether they have surgical problems. Like this, we screen up the patients and then we take them to our college or the hospital area, and then they are diagnosed for the particular complaints they have, and then physiotherapy programs are being started for them at their home, or either at the college level or the clinic level. So many times when we go to rural areas, I mean the women, mostly the women, they have lots of complaint about knee pain, back pain, neck pain. So then we start talking to them that what other problems you have, how you are working. We see their, I mean the environment of their house, the atmosphere of their house. And then we just give them some advices that you do like this, or you start this type of exercise. If you want, you can come to our clinic, and then we can help you in giving some modalities and treating your pain and all the things. Many times there are old age persons living there, and they have lots of complaint like we are not able to do this, we are not able to do that. So then we evaluate them and we tell them, you have that capacity that you can do this. And then they believe that yes, whatever we are telling them, they are able to do, because we make them do all those things in a group. We take them in a group, we make them do some exercises, we make them do some play games and all those things. So by that they are motivated, and then they again come back to their normalcy, that we can do this, and they start doing that work. So by this we can prevent lots of, I mean, burden on the society by giving them ergonomic advices, by motivating them, like you are able to do this. Suppose if you see the lady in these photographs now, she has her I mean she's cooking outside her house in the compound area. So we just talk to her that you can do this, but if you say your knees are paining, we ask her to prepare a stool in such a way that she can sit on that stool, and then she can do this her food, and she can prepare her food. So after that she got the stool prepared and she started doing all those things. Her all the complaints gradually were coming down, that now she doesn't have pain, she's enjoying cooking, she doesn't have any complaints. So like this, we are going to lots of villages nearby, and every week we have a camp. So we try to evaluate them, we try to guide them, and we re-evaluate them every week. So gradually the complaints, they get lesser and lesser. And most of the time in older age people, their frailty we see, because many times they say, I'm not able to walk even this much, I have to do this but I'm not able. So then what we try to help them in connecting with those type of people who can help them, take with them, just assist them to do their work. So in this sense, we try to, as a community, in community, and if I say preventive community physiotherapy, we give them in base of some exercise, ergonomic exercise, and we get good lots of results that they are able to do good work. They are able to do in such a easy manner. They are happy, so their whole environment, their mood changes. So by this we try to help them out coming back to their normal life. If you have heard, I have one rural area in Kutch, and then there is a place called Bidra. In Bidra, lots of patients of post-traumatic earthquake are there. Many, as we have seen in Dr. Mishra's slide, spinal cord injuries were the most common in that earthquake. And I'll tell you, this is a picture where we say, our gaon chale, and there we go with doctors, orthopedic surgeon, general physician, ENTs, gynecologists. We screen them, we do all these things, and then we bring back those patients to the institute. We go to the village, we treat there, we bring here. So by this, we try to help them out to come out from all those complaints. So prior I was talking about Bidra. In Bidra, we have a NGO set up uh, has set up a good rehabilitation center where the patients of these old spinal injuries or other fractures are being treated there continuously. Or if there were so many patients, amputate patients there, so the free prostheses were given, orthoses were given where needed. So like this, we try to help them out in their complaints, and we try to get more and more, uh, if we say more and more, we emphasize on their uh, home environment and check out what problems they have, and then we try to help them out. So from this, uh, at least we can involve our final year, our interns, our PGs in these preventive community physiotherapy programs. And by this, as a physiotherapist, as being said by Vimal Madam, Mishra sir, and Pavitra Madam, if whether there are social burdens, whether there are any other uh, programs where we can help them out to come, they can come out from that particular atmosphere and do the things. This will really burden the it will just decrease the burden of on the government for even disability, if I can say. Because if they can work by giving them such motivation, by giving them these physiotherapy programs, by giving them ergonomic exercises, they can work. They don't have to depend on others. So by this, we can very well lessen the burden of disability on the government by preventing this disease, and even by preventing the non-communicable diseases, by giving them good awareness of their lifestyles, so they can be prevented from all these diseases and lead a very good life. And the outcome will be, the quality of life will improve in villages, and most of the people in villages, they are working in the farm. So how they can be helpful in their farming, how the women in the house can, because they don't have those kitchens what we have in urban areas, the standing kitchen or all this. They have a kitchen where they have to work on those chulas, I mean, and sit down. And so by this, we help them to give them some ergonomic advices, and they can prevent those diseases which, as a physiotherapist, we can assist them. So this is the preventive community. Hello.
Thank you so much, ma'am. That was really very quite inspiring. You have actually, the question that we were to discuss on was role of community physiotherapy, how we can reduce the burden. I think you actually highlighted it very well. So I would just like to have a basic discussion with all our honorable panel members. As you gave an insight, because we have some time limit, so I'll be putting only one question for discussion. How can we as community physiotherapists contribute to reduction of this burden of disability in India? So can we start with Telang ma'am, please?
As I said, the burden of disability, our prime focus should be on we have to make a assessment of what is the extent of the functional impairments, the activity limitation and participation restriction that the person with disability have in the community. And if we are depending on what role we are taking, are we doing the role at the grassroots level, or are we doing the role as planning as policymakers? If we are policymakers, we have to have surveys which you have to find out what are the participation restriction and the quality of life. So accordingly, we have to change at the level of the health condition, we have to change at the level of the environment. The contextual factors also, it is a biopsychosocial, one cannot contest that. It is a biopsychosocial problem. So you have to intervene at the level of the person and at the level of the community. If you are doing it from a planning level, if you are doing as a clinician, as at the grassroots, you have to, each person is it is a customized program. You can't have a package. One has to remember it is a customized, since the biopsychosocial, the psychosocial factors are going to be very unique to that person. The context is going to be unique. So one has to find the context in which the person is having an impairment. So at the community, what is it that, when we are planning our programs, it should not be a square peg in a round hole. So it has to be specific. It has to be, you have to tailor make it, and you cannot, once you know what is the prevalence, what are the common causes, then we can make community IEC programs. That is, just as Pavitra said, that we have our information, education, and communication goes a very long way in tackling the community, in helping the community. I remember when we were doing a lot of projects, WHO projects, government projects in Raigad district, we did it in 5 different states of the country. Community awareness is a very, very important. And when we say community awareness, it's not just community awareness at the local level, at the village level, it has to be a top to down approach and bottom to up. Community awareness right from administrators. We have done community awareness for the IAS officers to the Sarpanch level, because the non-awareness of how much we as therapists can intervene and how much we can bring about the change. There is a lot of non-awareness. People are not aware the extent that we can do. So community awareness becomes the key, whether you are a policymaker or you have to start right from policymakers, because it comes to, I'll tell you simple things like we had a time when we sensitized the IS officers, the health secretaries, the civil surgeons. And when we did that, we finished that, within a month, they were transferred. So whatever we had done, it's not that it is undone, they carried it forward. So it has to be a sustained program. It has to go. And only then with that, it will go into the syllabi of everybody. So awareness becomes the key for any community. So to accept what we are giving, because whatever we are giving should be accepted by the community. Right. So otherwise it becomes more like a political jargon which patient. This is what we have learned, because when we went out into the communities in Raigad district, when we went out in Durg in Madhya Pradesh, they thought we were another political force that had come out. But what we did, we showed the work and then we went in. So you have to tailor make it to as what the community wants, because see, lot of things go into the community. So they are bombarded with so many things. So it is like how you present it and how so your presentation to the community, how you do it is very, very important. When I talk about presentation, it is not just oratory skills. It is the language in which you speak, how you present your dress code, your manner, your attitude. So many things and how you go in. You have to make friends with the health workers. You cannot enter the community directly. You have to make friends with the health workers. So we went into the primary health center. We spoke to the doctors. We met the DAIs. We met the health workers, the sanitary inspectors. We sensitized them first. Once they were sensitized and they knew, we showed them what we could do. And then you do it as an example. Do it as an example. Show the change.
Right.
School teachers, you have the resources are enormous. Community has enormous resources. We cannot say there are no resources. It is for us to tap, and we have to identify the resources.
Right. That's really, exactly up to the point. Yeah.
So resources are there. It is for you to see, identify.
True.
So we cannot say that there's a lack of resources in the rural. In fact, rural area is full of resources. Manpower resource is the most important, and you get a lot of manpower resource, and people are ready to help you. Senior citizens, sarpanch, you have your health workers, you have your school teachers. Lot of them are there to help. They will come out. Once they know that you mean business, you are out to help them. They will come out in numbers.
Thank you so much, ma'am.
Madam, I would like to tell one thing here, Apurva.
Yes, ma'am.
Like Vimal madam said, we have resources. What we do is, Ahmedabad Medical Association, they come with us, and as medical doctors, they are with us. They see the sarpanch, they explain to the sarpanch, and sarpanch tells to the village people that they are going to do this, and that is how the camps are organized, and that is how they have that faith that they are going to help us. That is the right thing what Vimal madam said.
So I think interdisciplinary team is a very important domain. Dr. Mishra sir, can I have your input?
Actually, both madam have pointed out right things. I will add something. In addition to that, actually, whenever you are organizing a camp, so it is in a temporary phenomena. You are sensitized the things. Actually, what I am saying, if a person, community physiotherapist, will go regularly, and he will find, because some problem is not permanent, some problem will come immediately. After sometimes it may go also. So during that period, patient is very agonized. So that is the reason why, like madam told about the back pain. So that type of things. So that is the pains which is causing more problematics, and limits activity limitations and participation also. So that is the reason why actually somebody should be there who can guide. Along with this this project, because you are going outreach, you are providing outreach services, or you are organizing the camp. After that, somebody should be there at least to look after everything, so that you can get particularly the society get more benefit. So in addition to that, in physiotherapy particularly, we are dealing with more impairment and activity limitations. But we are not thinking to assess or to organize our level of things so that participations things you are lacking actually. So you have to improve our assessment, particularly about the participations, how we can achieve really the participation. So that actually everything, because you are not thinking about that particularly as a human being, as a body structures problem, as functions problem, but not actually that it is also related to the many complex things, psychosocial things. So you have to think that way, and your assessment as well as the participations has to be assessed and has to be treated so that you can find a real goal in order to achieve this. So, and for that reasons, so as Madam told that you have to use many local resources. So, in my opinion, what we have achieved, so the people actually, those are disability people, particularly the spinal injury, those are already have already got the rehabilitations, already his activity level has improved. So this can be a role model. You can use them so they can understand the problem of the patient, and patient can understand also very well when this fellow will speak. Okay, I was this problem. Now I got this much improvements. So if you can go this way, so your life also will be very good. So that is the reason why also you can involve these peoples. And Madam rightly pointed out that also you have to use the administrative. Without the administrative and other peoples also, our goal cannot be fulfilled. So that is the things. Everything should be coordinated. Then only you can improve.
So three basic things I've got is modify the environment, be a
Yes.
team, and use local resources. Can I have your take, Dr. Pavitra?
Uh, Going back to what Dr. Telang mentioned, that there needs to be an awareness that needs to be improved. And I think published evidence in the
Mhm.
form of research is a very strong way to improve awareness, especially in the top level of the organization of community physiotherapy, be it in India or Australia. So that's the kind of work that I've been doing with community physiotherapy in India for the past few years through my publications, trying to interact with students, with the staff, with the stakeholders in order to understand how much aware they are of the role of community physiotherapists. And there doesn't seem to be much evidence on that end. So I think in order to create awareness, in order to get more people involved in the kind of work that we want to achieve, I think that's a very neat way to go. Like try to get more published evidence and publish the wonderful work that we all are doing, so that it can be a role model for the others also to replicate uh, what is being done. So I
So
think
finally, we are coming to the domain of let your work speak for you.
yes.
So, okay, thank you so much. I think we can go on with this. It's really something very interesting, but we actually have exceeded a lot on our time. So, on behalf of Scientifica 2021, I would like to acknowledge and thank Dr. Vimal Telang, Dr. Nita Vyas, Dr. Chittaranjan Mishra, and Dr. Pavitra Rajan for your contribution to this very wonderful seminar. And I thank you from all the entire organizing team. Uh, Thank you for participating in Scientifica. Have a nice and wonderful day.
Thank you
Thank
very
you.
much.
for
Thank you.
inviting us
Bye.
and for
Bye.
this wonderful